Good evening, everybody. Welcome to the last session of today. So this will be on traumatic as well as post-operative rises of intraocular pressure. As you know, these are very common scenarios that we have to deal with in daily ophthalmic practice. So to talk us through traumatic glaucoma and overview, we have Dr. Mini Jayachandran. She is a glaucoma consultant at Amardeep Eye Hospital, Kollam.
Thank you, Dr. Kiran. The topic is traumatic glaucoma, an overview. Secondary glaucoma occurring due to various mechanisms related to eye trauma is known as traumatic glaucoma. It's often underdiagnosed due to the delayed onset and the patient forgetting trauma history. Ocular trauma incidence in India is 4.6% and it's bilateral in 0.4% cases. The risk of traumatic glaucoma is 2.6% in open angle cases and 3.3% in closed angle cases. Ocular trauma or surgery can cause infiltration of bone marrow derived monocytes into retina and neuroinflammation by upregulation of tumor necrosis factor 11-1B and 116 mRNA within 24 hours. This is accompanied by ganglion cell apoptosis and neurodegeneration. Prompt inhibition using monoclonal antibodies protective against ganglion cell damage. Eye is protected from direct injury by lids, lashes and bony orbit, but it can be injured in different ways. Coming to Bett's classification of ocular trauma, can be either closed globe or open globe. Closed globe can be contusion or lamellar laceration. Open globe can be rupture or laceration, and laceration can be either penetrating or perforating. Each of these mechanisms of traumatic glaucoma requires a unique therapeutic approach aimed at medically or surgically treating it. Now coming to the classification, blunt trauma can be of early onset or late onset, and penetrating trauma, chemical, thermal, electric and radiation injury. Early onset glaucoma, the pathophysiology can be either trabecular meshwork disruption, hyphema, iritis or choroidal hemorrhage, traumatic iritis, trabeculitis. The choroidal hemorrhage leads to forward displacement of lens iris diaphragm and angle closure glaucoma. Late onset can be due to angle recession, that's a tear between the longitudinal and circular muscles of ciliary body, or it can be ghost cell glaucoma due to bleeding in vitreous cavity. The RBCs become spherical, rigid and clog the trabecular meshwork. Hemolytic glaucoma due to hemolysis of RBCs and hemosiderotic glaucoma due to toxic effects of iron on trabecular meshwork. Hyphema can be by two mechanisms, can cause glaucoma by two mechanisms. Trauma to globe leads to anteroposterior compression and simultaneous equatorial expansion, leading to tearing of blood vessels of iris and ciliary body. Sudden rise of intraocular pressure leading to tearing of blood vessels of iris and ciliary body. Less than half AC anterior chamber hyphema can cause 4% incidence of glaucoma, and if it's more than half anterior chamber, there is 85% incidence. Rebleeds can occur 2 to 5 days after the initial bleed, and the incidence is 20 to 25%. It is due to fibrinolysis and clot retraction. It's associated with higher risk of increase in intraocular pressure. Coming to the grading of hyphema, grade 1 is less than 1/3 of anterior chamber, grade 2 1/3 to half, grade 3 more than half, grade 4 is full anterior chamber. It's also known as 8-ball hyphema if it is dark red blood. Now angle recession glaucoma, blunt trauma forces aqueous humor laterally and posteriorly against the iris and angle. Traction on iris root causes tear between longitudinal and circular muscles of ciliary body. And the gonioscopy shows widened ciliary body band and increased visibility of scleral spur. If more than 180 degree of angle is recessed, there is more chance of glaucoma. Two peaks of onset of glaucoma, that is at 1 year and 10 years. Early glaucoma is due to trabecular meshwork disruption and ciliary body laceration, and late glaucoma is due to scarring and sclerosis of trabecular meshwork and Schlemm's canal. Then Coming to lens subluxation and dislocation. Anterior dislocation of lens will cause pupillary block. Posterior dislocation can cause vitreous prolapse and pupillary block. Then phacolytic glaucoma, also trabecular meshwork obstruction by vitreous in anterior chamber. Coming to penetrating injury, hyphema, lens dislocation, phacolytic or gaussial glaucoma. Then corneal injury causing shallow anterior chamber, peripheral anterior synecdoche and secondary angle closure. Then posterior synecdoche leading to iris bombay. Injury to lens causes inflammatory glaucoma. Epithelial downgrowth, retained iron foreign bodies cause siderotic glaucoma. Epithelial downgrowth caused by penetrating trauma or a patent fistula between external eye and anterior chamber. It leads to abnormal introduction of epithelial cells into anterior chamber and proliferation over the trabecular meshwork or angle closure due to peripheral anterior synecdoche formation. There are three forms of epithelial downgrowth: pearls, cysts and membranes. Membrane is the most aggressive form. Now coming to surgical trauma causing glaucoma. Cataract surgery, it can be due to retained viscoelastics, inflammation, hemorrhage, pigment dispersion, vitreous, peripheral anterior synecdoche or pupillary block. Glaucoma surgery can also cause raised IOP post-RAB. Then post-PA also can cause raised IOP. Then penetrating keratoplasty, Descemet stripping, endothelial keratoplasty, keratoprosthesis, vitreoretinal surgery also can cause glaucoma post-operatively. Post-penetrating keratoplasty glaucoma can be of early or late onset. Early onset due to viscoelastic sutures or large graft and inflammation. Late onset can be steroid-induced or persistent inflammation. Malignant glaucoma can occur following cataract surgery and glaucoma surgery. In glaucoma following retinal detachment surgery can be due to mechanical narrowing of angle due to indentation by the encircling band, can be caused by silicone oil or gas injection, and steroids, ischemia causing rubeosus iridis and neovascular glaucoma. Then retinal detachment itself causes release of photoreceptor outer segments into vitreous, which clogs the trabecular meshwork, that is Schwartz-Metzger syndrome. Acid injury causes tissue coagulation, alkali injury, tissue saponification. Glaucoma is more in alkali injuries. There is a bimodal increase in IOP. Early rise is transient due to scleral shrinkage and release of prostaglandins. Late rise due to trabecular meshwork damage, peripheral anterior synecdoche, and pupillary block due to posterior synecdoche. Then thermal injury due to hot water, hot cooking oil, fire explosion. Radiation exposure causes retinopathy and neovascular glaucoma. Electrical injury causes pigment dispersion. Periocular trauma causes caroticocavernous fistula, which can raise the episcleral venous pressure leading to secondary glaucoma. And the positive predictors of post-traumatic glaucoma are angle pigmentation, and if the baseline IOP is raised, there's more chance, hyphema, and absence of cyclodialysis cleft. Then if the angle recession is more than 180 degrees, also lens injury. Thank you.
So, having had a brief overview, now we'll hear Dr. Veena Vishwam from Amardeep Eye Hospital, Trivandrum, talking to us about traumatic glaucomas and how to medically manage them.
Good evening, everyone. First of all, I thank Dr. Kiran for giving me this opportunity. That was an intensive talk by Mini Madam and regarding the overview of blunt trauma and IOP rise in surgeries. Now, I will be dealing with glaucoma in closed globe injuries, evaluation and medical management. So, when Kiran asked me to present this, I was thinking how we clinically see such patients and how we approach such cases with blunt trauma, and how as glaucoma consultants we approach a blunt ocular trauma. So
It's covering the eye. I don't like that. Yeah, I think perhaps it's just above.
all of us sitting here might have seen one or two cases with shuttlecock injuries or ball hitting the eye, children brought to us in the OPD. And we know that the blunt ocular trauma, it directly causes an anteroposterior compression to the eyeball, and when the equatorial diameter increases and stretches the ocular cords, almost all structures in the eye are affected, like the angle, the lens, the retina, the ocular cords may get damaged, the optic nerve may be damaged, and even orbital fractures may occur. Sometimes patients with accidents or in RTA, when patients are brought to us, even brain injuries may be associated. So first, when we see, these are some of the causes we usually see in sports injuries, very common, then occupational injuries, road traffic accidents. Such cases are usually brought to us in the OPD, and sometimes even we see our favorite sports persons getting injured in the field. And as a consultant, what all should come to our mind when we are seeing such a patient? First, important things like globe rupture, traumatic optic neuropathy, retinal detachment, orbital fractures, emergencies should be ruled out. And then always we should keep in mind the chance of developing glaucoma in these patients as well. So as glaucoma consultants, what all things can usually give rise to a raised intraocular pressure in the blunt traumatized eye? Usually traumatic iritis is very common. Hyphema is another important cause of raised intraocular pressure in these eyes. Angle recession can cause raised intraocular pressure. Then lens dislocation, though it is not as common as the other causes, this is also an important factor we should be kept in mind. And in vitreous patients who have had vitreous hemorrhage, a chance of gauze cell glaucoma. Other causes like phacolytic glaucoma also should be kept in mind. I'll be only dealing with the important causes which we usually see in the OPD like this. So how do we diagnose and manage such patients? So in such patients, history gives very important clues. Usually unilateral presentation, detailed history should be taken, whether there is a history of trauma. Sometimes some infections, systemic infections like tuberculosis or some autoimmune causes can also lead to iritis, which may be mistaken for an ocular trauma. Then any history of recurrent use of medicines like prednisolone eye drops in the past, all these should be asked to the patient. 20% of iritis is traumatic, and usually it occurs in younger population. Torchlight examination will give very important clues. From the pupil, we can see whether there is an optic nerve injury. RAPD should be checked in all these patients. Then whether the pupil is mydriatic or miotic. Sometimes due to the nociceptive effect, the pupil will be miotic, or due to sphincter tears, the pupil may be mydriatic. There may be formation of peripheral anterior synechiae in the later stages, which can result in irregular pupil. Rule out other causes like redness, discharge, or anything is there. We have to rule out those other causes also, and always look for some signs of photophobia, which may give you hints about the traumatic iritis cases. Then slit lamp examination, we can see circumcorneal congestion, sometimes flare, cells, hyperpion. In viral keratitis and all, if there is associated uveitis, there you can see corneal scars, scapies. So these will rule out such causes which may be confused with traumatic uveitis. Then in trauma, you can see mostly in blunt traumas, there will be Vossius ring on the lens. And in gonioscopy, we'll get very important clues like if there is an angle recession or a cyclodialysis cleft or a microhyphema, some clues about a traumatic injury can be found out. Then always record the history of the patient. In all trauma cases, history, visual acuity recording is very, very important. Pupils, intraocular pressure, and dilated fundus examination is a must. Then in mild iritis case, how do you usually treat? Usually topical cycloplegics will keep the pupil dilated and prevent synechiae formation, and stabilize the blood aqueous barrier and prevent further protein leakage, and it will prevent ciliary body and pupillary spasm that causes pain. And topical steroids are usually given according to the grade of uveitis. In severe uveitis, you can give more frequent drops. In mild uveitis, the dose can be lessened. Then topical beta blockers are usually the first given along with the first line of treatment of steroids. Then the patients are usually followed up every 5 to 7 days at least, and the risk of rebound iritis increases if the steroid is not tapered. Then gonioscopy and indirect ophthalmoscopy, as I have already said, should be done on every visit. Prognosis is good, and some complications like glaucoma, cataracts, cystoid macular edema, etc. should be kept in mind on every follow-up. Then in mild uveitis, always rule out a corneal aberration which may sometimes be missed. If there is mild uveitis, retinal detachment also may be associated, so look for that. Always keep in mind the chance of an endophthalmitis which may be there along with some open globe injury while examining a patient with blunt trauma. Now going to the second important cause of raised intraocular pressure in blunt trauma, hyphema. Hyphema, blunt trauma is one of the most common cause of hyphema. Clues, as I said earlier, from history, almost all these cases may have associated findings, like uveitis patient may be having hyphema, microhyphema, or angle recession. So always you have to look for all these things in all such patients. History of trauma, torchlight, I think I need not repeat all this. I have already said this. A B scan may be useful when dealing with patients with total hyphema to understand the status of the eyeball, inside of the eyeball. Sometimes if you are suspecting open globe injury in a case of hyphema, CT or MRI may also help you come to the diagnosis. In a slit lamp examination, the hyphema height should be measured so that you can see how it is regressing. Also look for other findings like iridodialysis, sphincter tears. Sometimes mostly hyphema patients, because of the extent of injury, it may be associated with with phacodonosis or iridodonosis, and a chance of rebleed should always be kept in mind while you are treating a patient with hyphema. Mini Madam has already said in detail about all this. Hyphema grading is important because according to the grade of hyphema, the chance of IOP rise also increases. So the chances of the patient developing higher IOP increases according to the grade or severity of hyphema. Also, rebleeding hyphema also leads to raised IOP. The chance of raised IOP is high in rebleeding hyphemas. So we all know how to manage hyphema. Though there are different studies which give different opinions, limited activity and eye shield, keeping the head elevated position so that the hyphema settles down due to gravity, such things should be kept in mind. And antifibrinolytics has some role. Systemic or topical and Tranex or alpha aminocaproic acid may help. And I am not going to the details. It is an analog of amino acid lysine, and it inhibits plasmin, which is involved in fibrinolysis, and it prevents the normally occurring clot lysis, which usually occurs after the 5 to 6 days. And that is what usually results in a rebleed. So in rebleeding cases, Tranex is usually found to be effective. The dose is 50 milligram per kilogram, and a maximum of 30 grams per day QID may be given. And it is usually contraindicated in active intravascular clotting, thrombosis, hemophilia, and renal failure patients. Corticosteroids, prednisolone has an important role. It stabilizes the blood aqueous barrier. Topical prednisolone has a role, but even systemic prednisolone is found to inhibit fibrinolysis. So prednisolone is also systemic. Even systemic prednisolone also helps in stabilizing the clot and preventing rebleeding. Atropine is also given to keep the pupil dilated. Then the role of conjugated estrogens like primarin, which increase prothrombin concentration and decrease antithrombin activity, is also debated, and some doctors prefer to give this as well. And it is also known to reduce secondary hemorrhage. So when do we hospitalize hyphema patients? Usually, if it is children or non-compliant patients, sometimes may require hospitalization. Patients with bleeding diastasis or blood dyscrasias are usually hospitalized. Patients with severe ocular or orbital injuries, we know that needs hospitalization, and patients with concomitant IOP elevations with sickle cell disease also needs hospitalization. Aspirin and NSAIDs can increase the risk for further bleeding, and so such medicines are avoided, and for pain relief, indomethacin or such medicines are usually given. Surgical treatment in sickle cell disease, if the IOP is more than 24, and if the non-sickling cases, if the IOP is 60 for more than 2 days, and if the IOP is more than 25 with total hyphema for at least 5 days, and if the cornea is getting stained with hyphema, or if the hyphema is failing to resolve to less than 50% for 8 days, we may go in for a surgical removal. But it depends upon the treating surgeon how to follow up this patients. And in clotting disorders, we give an infusion of the deficient clotting factors for the first 5 to 6 days, and always keep in mind in children the chance of amblyopia. In children also, alpha-aminocaproic acid and systemic steroids are given. In sickle cell disease, there is an increased risk of hemorrhage, and there is a high risk of developing high intraocular pressure, optic atrophy, secondary hemorrhage, and even central retinal artery occlusion. Timolol, brimonidine, dorzolamide, methazolamide, topical dorzolamide. Dorzolamide is not usually orally given. Topical dorzolamide can be given after giving timolol and brimonidine if the IOP is not getting controlled. Topical dorzolamide can be given. Then methazolamide can be given, and usually hyperosmotic agents like mannitol and glycerin are usually, oral glycerin are usually avoided because it may lead to hemoconcentration in sickle cell patients. Systemic carbonic anhydrase inhibitors can lead to systemic acidosis, and sickling will be increased. So these drugs are also avoided in sickle cell patients. Now coming to angle recession, 60% of eyes with blunt trauma will develop angle recession, some degree of angle recession, and a small percentage may develop of such patients will develop glaucomatous optic neuropathy and vision loss even months or even days or months or years later. In gonioscopy, we know that in angle recession there will be asymmetry of the angle recess, widening of the ciliary body band, retro displacement of the iris root, irregular or darker pigmentation in the angle, whitening of the scleral spur due to visibly fractured iris processes, and associated peripheral anterior synechiae, iridodialysis or cyclodialysis also may be present. So cyclodialysis cleft should always be kept in mind while we are dealing with an angle recession patient, because the IOP will be low at presentation. Even if the patient is having an angle recession, the IOP may be low, and we may but these cyclodialysis clefts may close by themselves after a few weeks or days, and later the pressure in the eye may rise, resulting in high intraocular pressure. So these patients should be followed up, and usually the cyclodialysis cleft patients will also have increased pigmentation of the angle and wider angles, and if the angle recession is more than 180 degrees, it is a significant factor to develop glaucoma. UBM plays a very important role in identifying angle recession patients. Long-term scarring and fibrosis of trabecular meshwork or Schlemm's canal and elevated pressure can occur over the years, and difficulty to control medically and surgically. counseling and regular follow-up is very important in angle recession patients. Treatment is topical aqueous suppressants. Prostaglandin analogs are usually avoided in the acute phase, and later as it bypasses the dysfunctional trabecular meshwork and increases the uvascular outflow, it can be used in the later phases. And pilocarpine is reported to exacerbate angle recession. Now coming to lens dislocation, Mini Madam has already told you the ways by which lens dislocation can cause raised intraocular pressure. Anterior dislocation can result in pupillary block and raised intraocular pressure. Posterior dislocation can result in prolapse of the vitreous into the anterior chamber and result in pupillary block. So anterior subluxation should be checked. Inflammation associated with dislocated lens can cause IOP rise, phacolytic glaucoma, or obstruction of trabecular meshwork by vitreous prolapse, or chronic angle closure from peripheral anterior synechiae. All these can cause IOP rise in these patients. UBM also sometimes give clues regarding this. We had a case, 84-year-old patient with history of fall, actually a pseudophakic patient. She came back to us with pain and intraocular pressure of 60. And I could not show you the vitreous in the anterior chamber clearly. That's why I have just marked. That was a pupillary block due to the vitreous coming into the anterior chamber and filling the anterior chamber through the pupil. So the patient had severe pain and pupillary block, and the pressure was 60. And this was because the posteriorly dislocated lens had come forward when she was sitting, and sitting in her sitting position. The lens came forward and blocked the pupil, and when the vitreous also came into the anterior chamber, the pupillary block was there. And this patient, we did a PI, and her intraocular pressure came back to normal. There is in the literature, there is a sign called the floating lens sign. That is, when the lens is dislocated, it can go and fall back. In the axial CT, we can see in the supine position that the lens will be falling back and will be falling at the back side of the globe. When the patient is asked to hyperextend the neck, and when a coronal CT is taken, the lens will fall back on the posterior part of the globe, and we can see the position of the lens in CT scans. So treatment, as I told you, mannitol, acetazolamide, cycloplegics, supine position, and PI. Supine position will cause the lens to fall back and the pupillary block to get relieved. So such patients due to lens dislocation needs lens removal if the pressure is rising, and if there is a lens-induced acute angle closure due to pupillary block, persistent uveitis, or lens corneal decompensation. Now the last one is ghost cell glaucoma. It is usually a clinical diagnosis. Clues are IOP spikes and vitreous hemorrhage 1 to 3 months prior to presentation. IOP may be markedly elevated with corneal edema, and ghost cells may be there in the anterior chamber. Disrupted anterior hyaloid phase. Gonioscopy will show open angles and ghost cells layering the inferior angle due to gravity. Fine layer of khaki-colored cells may discolor the trabecular meshwork. Pseudo-hypopyon and appearance of old hemorrhage, khaki coloration of RBCs, and clumps of extracellular pigmentation from degenerated hemoglobin and heme in vitreous. Candy striped appearance, as you all know, may also be there in the anterior chamber. Usually it resolves once the vitreous hemorrhage has cleared, and aqueous suppressants and oral and carbonic anhydrase inhibitors can be added. IV mannitol or Diamox may have a role. Prognosis is excellent, and uncontrolled IOP may lead to optic nerve damage, but once the supply of ghost cells is exhausted, it will cease to accumulate in the anterior chamber. Now watch out for signs like sequelae. Any sequelae can be there, like I told you, peripheral anterior synechiae formation, or angle recession, getting cyclodialysis cleft, changing to raised intraocular pressure. Such sequelae should be watched for, and recurrence of bleeding into the anterior chamber, or uveitis, and steroid-induced glaucoma is another factor which should always be kept in mind, because we are treating the patient with long-term steroids, and such steroids can, in the long run, result in raised intraocular pressure and glaucoma. So, prevention also has a role. So, protective helmets or protective gadgets should be worn, especially for sports people. And thank you.
Thank you, Dr. Veena, for the detailed presentation. Now, next speaker is Dr. Kiran Balagopal. He will be talking to us on management of IOP elevation after ocular surgeries other than glaucoma surgery.
Okay, so I'll be mainly speaking about the medical management part. IOP elevation can occur either in the early stage or late after surgery. Common surgery scenarios are cataract, via surgery and corneal surgery. Here the threat to vision is very unpredictable. Moderate small spikes are very common, but what you have to be careful is extremely high IOP spikes and even moderate spikes in eyes with pre-existing glaucoma or damage to the optic nerve. In evaluation, you have to know the details of the surgery. This is easy if you are the primary surgeon, but if not, you have to sit with the primary surgeon and have a good discussion. Then you have to find the mechanism of IOP elevation. Is it a closure? Is it an open angle? Is it pre-trabecular, trabecular or post-trabecular? And then treat accordingly. You have all the normal tools that a glaucoma specialist has, but the way you use them and their effectiveness may be varied. Sometimes you may not be able to do a proper tonometry, your tonometer may not work, or the patient may not be in a condition to give you accurate IOP values. Gonioscopy may be difficult. You have slit lamp 90D, and if you're lucky, you have the UBM, B-scan, etc. But sometimes you have to rely on your clinical judgment and digital tonometry. And in your armamentarium, you have the normal all the usual drugs are there, but you have to be extra careful with the PG analogs, pilocarpine and topical carbonic anhydrase inhibitors. Let us come to cataract surgery first. There are some risk factors which Mini Madam has already touched upon, and let us directly come to a case where the patient complained of defective vision and mild pain in one eye 1 month after SICS cataract surgery in a high volume situation done at a hospital in Calicut. She was the mother of a doctor. In the right eye, the vision was 6/60. Reportedly, it was much clearer immediately after the surgery. IOP in the right eye was 46. Left eye also was high, 26. The right eye was white, and there was corneal edema. The right pupil was sluggish due to the high IOP probably, and PCL was there, and left eye pupil was okay, NS3 plus PSC. And because of the corneal edema, fundus view in the right eye was poor, and because of the cataract, fundus view in the left eye was poor. So we only had the IOP and the corneal edema. So initially we thought it is a steroid response and stopped the steroids and started beta blockers. After 1 week, vision was 6/60, applanation still was 6/60, applanation 32, and off steroids, and we dilated and saw the fundus and found that the cupping was 0.8. So this was a case of missed POAG which underwent a cataract surgery and developed a steroid response on top of the POAG. So after the patient was started on beta blockers and latanoprost was added, the IOP came back to normal and the patient became fine. Another patient, a unilateral cataract post-trauma. There was a 3 o'clock hour zonular dialysis with vitreous in the AC. After a vitreous clearance, I did a CCC and placed a CTR and did a routine phacoemulsification. First day, patient was okay, 6/9 vision, but there were 4+ cells in the anterior chamber. By the end of the first week, patient had pain and corneal edema. Vision had dropped to 6/60. IOP was 42. AC cells were 4+, mainly pigmented cells. With Diamox and Combigan and steroid hike, the IOP came down to the low teens in 3 days. And with maximal dilatation, I could find that some part of the IOL was probably outside the capsular bag. So I again took up the case to the OT and used some hooks to retract the iris and found that the edge of the haptic had come out through the CCC, because the CCC was not well centered on the crystalline lens. It was centered on the pupil, so one edge of the CCC was closer to the equator, and through that the edge of the haptic had come out and it was rubbing on the posterior surface of the iris, causing a pigment dispersion. So this was a case of secondary pigment dispersion glaucoma, and it needed a repositioning of the lens. I redialed it, and then the patient was fine. Then we come to another more recent case. The patient presented after 7 weeks of uneventful phaco surgery, and he was off steroids after 1 week off steroids with pain, redness, and blurring. Vision was 612, applanation 20 in that eye. There was some circumcorneal congestion, clear cornea relatively, pigments on endothelium. AC showed 3+ cells, pupil was mid-dilated, IOL and fundus were okay. And I didn't see the case. Another of my juniors had seen the case. So they diagnosed a case of post-operative uveitis, having stopped the steroids and restarted on moxifloxacin plus dexamethasone 2 hourly and added nepafenect. So after 2 days, the vision suddenly decreased to 6/36 and the IOP went up to 55. So on re-examination, the right eye had corneal edema, pigment clumps on the endothelium, AC was deep, pupil was still mid-dilated, not reacting, fundus view was hazy. After 2 tablets stat diamox, fundus view was clear and fundus appeared normal. This was the picture after the IOP came down. And did a gonio and found that the gonio showed open angles with heavy pigment 360 degrees. Areas of pigment loss were seen on the iris close to the pupil edge. Pupil was not dilating. So hiked up the steroids and gave diamox TID, Combigan and Dorzox. 1 week later, still the IOP was high despite diamox 3 times daily. Vision had improved, cells were still 3+ and pupil was same. And IOP remained between 20 and 30 with intermittent spikes, and after 1 month the IOP became normal. And then the patient developed some influenza, and he was lost to follow up for 3 weeks. And after that he came back with a normal IOP, only on topicals. He had stopped all the diamox. Then I found that the pigments were also not there. Then I again checked his IOP by applanation, and the next day he called me and said that he has again developed irritation. Then I called him the very next day and saw that he had again developed pigmented cells in the anterior chamber, and there was some circumcorneal congestion. This happened 2 or 3 times. Every time the patient comes with a quiet eye, I examine with IOP checking also, and next day patient develops pigment dispersion and also pain and uveitis like features. So on retrospective thinking and also some Google search, I found it out to be, I think it is a case of a unilateral case of body, that is something known as a bilateral acute depigmentation of the iris, or a bilateral acute iris transillumination. Here there is not much transillumination, but this is seen when the dosage of moxifloxacin given after the cataract surgery is it's an ocular toxicity of the moxifloxacin, probably because the dosage of the moxifloxacin intracamerally was a little on the higher side. And about the IOP spikes and inflammation spikes, I think it is due to the moxifloxacin drops applied at each visit after the applanation. So I'd like expert's opinion also regarding this case at the end. Next we have pars plana vitrectomy. Even if it is uncomplicated, 10 to 20% people develop glaucoma. The first month is very critical and they have to follow proper head positioning as advised by the retina specialist. It can be an either open angle or angle closure glaucoma, and the commonest is pupillary block, then comes steroid response. So 3 things, either buccal or silicone oil or gas. And when you place a buccal, if it's a high buccal, encerclage or anterior to the equator, it can impair the venous drainage from the vortex veins, causing ciliochoroidal effusion. This causes a congestion and anterior rotation of the ciliary body, pushing the iris lens diaphragm forward, and it causes an secondary angle closure glaucoma. So in cases of very hazy corneas, you can use glycerin to clear the cornea, and also if you have access to anterior segment OCT, you can use that to find the status of the angle. So then you have to use intensive steroids and maximum dilatation cycloplegia and laser PI if required, and loosen very tight buckle. And let us come to silicone oil. Silicone oil is a very buoyant thing, and when the patient sits upright, it can compress the superior angle and develop glaucoma. 50% of patients with silicone oil do develop IOP elevations. and in the early stage mostly due to pupillary block, late stage mostly due to emulsification and migration into AC, more with the low viscosity oils of 1000 centistokes or still than with the high viscosity newer ones. Also neovascular glaucoma is also quite common in the late stage. With regards to gas, it is more with C3F8 because it expands more and stays longer, and it can be either an open or angle closure mechanism. With regard to gas, only one thing, that is the IOP measured even with the relatively low displacement tonometers like applanation or Donopen, they can be falsely low. So you have as low as you can be underestimating the IOP by as much as 15%. So whatever gas you use, it's better to use an isovolumetric mixture like 20% SF6 or 14% C3F8. Head position is important, and when it enlarges, when it expands to maximum size, that is the time when you get maximum risk of glaucoma. You can treat it with carbonic anhydrase inhibitors, beta blockers, or alpha agonists, and you have to remember that all types of mechanisms can be at work here. Good thing about gas is that it gets absorbed after some time, and so risk of glaucoma also goes away. This is another case, that is PDR with vitreous hemorrhage, underwent a very big surgery at a different hospital, and at the end it was closed with air, and patient developed headache and vomiting. And when she came to us, she was on Diamox, Combigan, Dorsox, Homide, antibiotic and steroid, and vision was PL, and IOP was 48. The patient was on Diamox ER, so that was made to QID and also given mannitol IV. Then the IOP did decrease. So the question here is, does mannitol work after vitrectomy? Theoretically, mannitol shrinks the vitreous, so if vitrectomy is complete, it should not work. But vitrectomy, usually some part of the vitreous is left behind, so that does shrink. That is one mechanism. And also mannitol acts on the hypothalamus via osmoreceptors. It causes a decrease in aqueous secretion. That is also another way through which it works. Next case, it was a pre-existing glaucoma. TRAB IOL were done already on latanoprost and very deep cup, and he developed an RD, underwent RD surgery with silicone oil insertion, and initially there was some IOP rise that subsided, and after that at 4 months underwent silicone oil removal. Next day there was hand movements vision, epithelial edema, trace hypopyon, TAS was diagnosed and treated with systemic and topical steroids, which were weaned off pretty quickly. After 1 month postoperative, patient still was on latanoprost when he developed CME. So latanoprost was stopped and switched to Diamox and topical medicines like Combigan. And after 8 months, vision improved, CME decreased, and latanoprost was restarted. So patient did not redevelop CME after that, but field loss was there mainly due to the RD. So this is just to highlight that prostaglandin analogs, especially with vitreous surgeries and aphakic eyes, can predispose to CME. Next case is a case of silicone oil for RD, suddenly presented with pain, headache and vomiting, vision HM, IOP 52. So corneal edema was initially cleared with Diamox and mannitol, and gonio done. There was iris Bombay and multiple YAG PI were performed, and on topicals IOP decreased, but at second week the IOP shot up again and PIs all closed, and PIs were reopened again and came 4 or 5 times for repeat PI, and then was lost to follow up. But she went to the original place of surgery and then had a silicone oil removal, and again came back. At that time 80 was only 8, vision had dropped to PR inaccurate. This was the final picture, 360 degree PAS, 360 degree PS, and all fibrotic tissue over the IOL. After keratoplasty, nearly 33% patients develop glaucoma, and this is the second most common cause of graft failure. But here the important thing is the corneal thickness may be variable. So applanation may not give you a correct picture always. So tonopen may be a good idea. There are many risk factors like already mentioned, but here one unique risk factor is the suturing. Superficial sutures, tight sutures, or same sized donor, large graft, etc. These can cause compression and collapse of the trabecular meshwork, and that can lead to glaucoma. And I'll just come to issues of surgery. Any surgery for glaucoma after PK carries a 30% risk of graft failure. At any rate, we have to avoid a shallow AC, and in the first surgery PK itself one or more patent PIs are a must, and whenever TRAB is done, it has to be combined with MMC or any antimetabolite. A tube in the AC is very risky, it will cause graft failure. Better to place in the pars plana if possible. Sometimes you may even have to resort to cyclophotocoagulation for refractory cases. And let me come to a case, final case. Underwent a KP for fungal corneal ulcer with hypopion, therapeutic KP. First day graft was clear with epithelial edema. Immediately you have to suspect that IOP is high if DM folds are not there the first day. So IOP was high, given Diamox and Combigan controlled, and it remains stable near 16. At 6 months everything was clear when the patient developed a brimonidine allergy. So switched to dorzolamide plus timolol combination. Then again IOP was normal but presented after 3 weeks with blurred vision, 6/60. There was diffuse graft edema, shallow DM folds, and AT was 12. So suspected a graft rejection and hiked the prednisolone to 1 hourly. No change in 2 days. So then suspected sodium potassium ATPase pump blocked by the topical carbonic anhydrase inhibitor. So stopped dorzolamide and switched to netarsudil when the patient became fine. So I think I'll wind up my presentation, already running short of time. Thank you so much. Now now we have Dr. Neetu Mohan. She is Chief of Glaucoma Services at Aravind Eye Hospital, Chennai. She will be talking to us about the surgical management of post-traumatic as well as post-surgical glaucomas.
Good evening. I thank organizers KSOS and Kiran for the chance to be here today to catch up with old friends and meet my most respected teachers. It has been great to be back. So I'll just be putting together a few interesting videos and some surgical aspects of managing traumatic glaucoma. So indications for surgery are few, fortunately, but we'll go through a few of those. So as already mentioned, 20 to 30% of all eye injuries develop some kind of glaucoma or the other, or at least a transient rise in intraocular pressure. Indications for surgery are very limited, but when they present, they are often quite challenging. So as already again mentioned and covered in detail, it is important to document, since very often there are medico-legal issues involved. It is very important to document all the findings, history, etc. I will only stress upon this extra point, which is assessing the visual prognosis. It is important to know the visual prognosis rather than the actual vision. Why is the patient having PL vision? Is it vitreous hemorrhage? Is it a hyphema? Is it corneal decompensation? Or is it a funnel-shaped artery? It is important to assess the visual prognosis before you go ahead with a challenging surgery. The rest of the things have been already covered, so we'll skip that. Hyphema management again has been covered in detail. So the only point that I would like to again stress is the role of antifibrinolytics. Most of the things that we know is still theoretical. We don't really know whether there is a reduction in the risk of rebleed with the use of antifibrinolytic agents. There is also a school of thought that they probably also delay clot resorption. So except in recurrent hyphemas and patients with bleeding disorders, we still do not know if this is beneficial to all our patients. Indications for AC wash, we are traditionally taught that these are the indications for AC wash, but very often when a patient has a dispersed hyphema for 3 weeks and he is reviewing with you every week, sometimes you don't have an option, but go ahead and do an AC wash. But it is important to remember that we need to wait at least 2 weeks, because before that there is a high chance of rebleed. After that, if it is still a dispersed hyphema, we may have to go in and do a wash. So this is something I learned the hard way. So this patient already had poor vision in this eye, and he presented to us about 3 months after a further drop in vision. He was not very concerned because he already did not have useful vision in this eye. But his vision at this point of time, as expected, was hand movements. IOP was well controlled on anti-glaucoma medications, but we decided to do an AC wash and see. B scan was done prior to this to rule out a masquerade syndrome, and I spent 5 minutes trying to remove this with Vanners and Cinco cannula and whatnot. But it was like a literally solid structure there. And only when I used the anterior vitrectomy probe, I realized how easy it is to remove that. And then when I went back and read up, of course, it is given everywhere that you look for a delayed clot, removal of a delayed clot. You are supposed to use anterior vitrectomy because there is less traction on the adjacent structures and there is less risk for a rebleed. So this works very well in these old blood clots. So he had reasonably good improvement in vision following this. And angle recession again has been discussed in detail. We'll only go through the management aspect of it. So in medically controlled glaucomas, we just prefer to do a cataract surgery in these patients. When angle recession glaucoma and traumatic cataract coexist, medically well controlled on 1 or 2 medications, we just go ahead with the cataract surgery. Now, of course, we have the option of combining it with MIGS, either a KDB glide goniotomy or a tenito hook microtrabeculotomy or a GAT, or at least a 180-degree GAT. These options are provided to the patients. In medically uncontrolled glaucomas, you have the choice between a trabeculectomy or a glaucoma drainage device combined with a cataract surgery. Again, you need to consider all the other aspects, like look at the patient holistically. If it is a scarred conjunctiva with vitreous disturbance, deranged anterior segment, whenever there is vitreous in the anterior chamber, or persistently high IOP on medical treatment, or history of a previous intraocular surgery, we prefer to combine it with a glaucoma drainage device rather than a trabeculectomy when we do a cataract surgery. So this is a patient, as you can see, post-trauma, traumatic mydriasis. There is also some traumatic aniridia there, and there were a lot of vitreous strands all across the anterior chamber. The IOL fortunately was still stable. IOP was uncontrolled on maximum medications in 40s. So the safest thing in this patient was to just do a glaucoma drainage device, since the only point of entry is the 23 gauge needle entry that you create for the tube. So this was absolutely safe rather than doing a trabeculectomy with all that vitreous in the anterior chamber. So we tend to use Orolab aqueous drainage implant, or the RD. So the superior rectus and the lateral rectus were isolated after the traction suture. And I pre-ligate the RD with 2 7/0 vicryl sutures. So we expect the tube to open around 4 to 6 weeks post-operatively. Nowadays we also use a ripcord suture, but in this patient I did not use it since the preoperative IOP was very high. So once a plate is stuck under the muscles, 9/0 is used to fix the plate. The tube is cut. I left it relatively long since there were a lot of vitreous strands. We use a long scleral track, 4 mm long, with a 23 gauge needle which is bent, and enter into the anterior chamber. It is important to change the direction as you enter into the anterior chamber so that the tube lies away and not pointing towards endothelium. So the direction of the scleral track will be completely different from the point of entry into the anterior chamber, just like how we do an SICS. So the tube is placed into the anterior chamber and fixed with 9/0 nylon again. And since this patient already had a cataract surgery, though this technique can be done as patch-free tube, I did place a partial thickness corneal patch graft and an anchoring suture. So he did well post-operatively. So Gosel, hemolytic and hemosiderotic glaucomas have already been described in detail. So just coming to the medical management, as already discussed, anterior chamber wash with or without a pars plana vitrectomy and a surgical PI is to be done in all these patients. Whenever we go in, we prefer doing a surgical PI in these patients, because post-operatively, if there is an IOP spike or an inflammation and pupillary block, it is very difficult to go and do a YAG PI then. So when an extensive surgery is planned, we ask the retina people to combine it with a surgical PI. And if still refractory, we may have to plan a glaucoma drainage device. Lens-induced glaucomas, again, lens in AC is an absolute surgical emergency with a high risk of corneal decompensation. Emergency lens extraction with or without an IOL implantation has to be performed, and preferably combined with a surgical PI. anterior subluxation of the lens causing secondary angle closure glaucoma with pupillary block, whether to go for an immediate surgery or manage the patient conservatively will depend upon the presence of a visually significant cataract and the best corrected visual acuity of the patient at that point of time. In medically uncontrolled glaucomas and when cataract surgery is warranted, we prefer to combine it with a trabeculectomy or a glaucoma drainage device. So this patient had angle recession glaucoma with a subluxated traumatic cataract, but there was no vitreous in the anterior chamber. IOP was reasonably controlled on medical management, though he was on 2 or 3 medications. So we decided to combine a trabeculectomy with a cataract surgery. As you can see, it's only 2 to 3 clock hours of zonular dehiscence there, and there is no vitreous disturbance. Capsule hooks were used in that quadrant alone. And after a good hydrodissection, cataract surgery was completed. A CTR was placed in the bag. Cortex aspiration was done and IOL placed in the bag. So there was no vitreous disturbance at any point of time, so I was happy combining with the trabeculectomy. If there is a vitreous disturbance and there is a need for an anterior vitrectomy, then post trabeculectomy, suture release, massage, all becomes it becomes you cannot predict the outcome. So in such cases, we prefer to combine it with a glaucoma drainage device. So posterior subluxation of the lens, once the inflammation is treated and secondary glaucoma is under control, better to plan a pars plana vitrectomy with lensectomy with or without IOL implantation in the same setting. Open globe injuries should always be suspected when the history is there of a high velocity injury, and the possibility of a cell seal wound should always be ruled out even in the presence of moderate glaucoma. Cell seal wounds can present with borderline rise in intraocular pressures, and the presence of an intraocular foreign body should be ruled out in these patients when the history suggests that it is a high velocity injury with probably the presence of a foreign body. It is important to look for a corneal or scleral entry wound, perform a good Siddle test, and perform relevant investigations like orbital radiograph, gentle B scan, etc. to rule out an intraocular foreign body. I don't know if there are residents here, but this is my favorite video to show every resident who comes to our clinic how to perform a good Siddle's test. Under the slit lamp, actually paint the point where you expect that there may be an entry with the fluorescent strip, and even pinpoint leaks can be easily detected when you actually do it on the slit lamp. So open globe injury, as already described, can cause secondary glaucoma by flat AC and inflammation causing peripheral anterior sine AK, causing secondary angle closure glaucoma without pupillary block. You can also have SACG with pupillary block, and you can also have fibrous growth, which all of these will need a glaucoma drainage device. To conclude, the most important point that you should take back from this talk is always assess the visual prognosis of the patient before dealing with the case. Treat inflammation, medical management, lens in AC is an absolute surgical emergency. In a high velocity impact, always rule out the presence of an intraocular foreign body, perform a Siddle's test. Surgery is indicated only in refractory glaucomas. Most of the patients do well on medical management. Trabeculectomy may work in selective cases. Glaucoma drainage devices are required in most cases when surgery is indicated. Posterior segment evaluation to be done every time before taking up the patient for surgery, and lifelong follow-up. Thank you.
Thank you, Dr. Neetu, for that concise but comprehensive talk with videos. So if the audience has any doubts or questions, we can take them up now. I had a question for Dr. Neetu. In your practice, have you seen cases of pigment dispersion with secondary uveitis and glaucoma due to moxifloxacin?
That's what I wanted to share. We had also published that. I was hoping you saw it. So we had a similar case of Bate and Bardi, but it was bilateral, and most of the literature reports actually following systemic moxifloxacin. So this patient had gone with some symptoms suggestive of flu. She had gone to a doctor, received an IV injection. She had no idea what was given, but she presented to us, luckily during COVID time, so we had a lot of time to spend with her. And she had this intense pigment dispersion, which we knew that this cannot be pigmentary glaucoma. We had never seen that kind of pigment dispersion ever before or ever after that, and velvety pigmentation of the angle. But it is reported to be self-limiting, bilateral, and recurrence I don't know, because unless there is again a trigger, I don't know if it can recur. So after intravitreal and intracameral, I think there are a few reports, but not many. So, but this patient, one eye was self-limiting, the other eye we waited it out, but it would not resolve, so we had to do a trabeculectomy in one eye.
As regards my case, I have seen one more case that was done elsewhere, PMMA IOL in the bag, but pigment dispersion, heavy pigment at the angle, and IOP elevation. This is also nearly 1.5 months after the surgery. And when I asked Thomas sir at Chaitanya Trivandrum, he also says that such cases are not very infrequent now, probably due to the large quantity of moxifloxacin people inject. And in my practice, sometimes the sister loads 1 cc moxifloxacin and gives it to me, and if we are not careful enough, we end up injecting more than 0.1 cc. So now I inject very little and make a point to wash the AC slightly after that. Okay.
But if it is recurrent, maybe a UBM should be done before we decide that it is bait or body. That is something.
So in a case with PC rent or vitreous in AC, you don't recommend routine trabeculectomy at all?
If there is a significant amount of vitreous in the anterior chamber and we have had to do extensive anterior vitrectomy, once we have started, if we have done a flap already, we do a small ostium and close it. But if it is anticipated, we prefer a tube. Whenever the bag is not intact, usually we prefer a tube.
Okay, madam, thank you so much. And Dr. Tina, you have a question?